So good morning, good afternoon, and good evening. I'm Pascaline Caruel. I'm the marketing manager of Thermo Fisher Scientific for the prenatal screening portfolio. And I'm really pleased to welcome you today on this webinar on behalf of Thermo Fisher Scientific. So today is the World Pre-eclampsia Day, and this is a day where we want to raise awareness on pre-eclampsia, and we are very honored to welcome you on this webinar. Before I will be introducing our speakers, I really would like to give you a little bit of housekeeping information. So what you can see here is the overall screen where there is different part of the screen. So you will see always who is the speaker attending. So if you go into the slide area, you will have the possibility to see the current slide. For the Q&A session, so we will have at the end, after the presentation, the Q&A session, you will have the possibility to ask questions. So it's also possible during all the presentation of the speakers. You just have to click on the Q&A box and write your question and submit. And then we will discuss all this at the end of the presentation. So for the general recommendations. So for the best viewing experience, we recommend you to have a wired internet connection and to close any program or browser session that will be running in the background that could cause some issues. So the webinars are bandwidth intensive, so closing any unnecessary browser tabs will help conserve the bandwidth. So the webcam is being streamed through your computer, so there is no dialing numbers. For the best audio quality, please make sure your computer speakers or headset are turned on and the volume is up so that you can hear the presenters. You can find additional answers to some common technical questions located in the Help Engagement tool at the bottom of the screen, the yellow box. So now I'm really pleased to welcome our first speaker, and I really would like to introduce you to Silke Mader. So Silke Mader has been a passionate and influential advocate for maternal and newborn health for over 20 years. She built on her personal experience that she's going to share with us to improve care for parents, preterm babies, and sick newborns. So she established the EFCNI, so the European Foundation for the Care of Newborn Infants in Munich in 2008. And one of the major achievements of this foundation was to establish the World Prematurity Day, the development as well as the implementation of the European Standards of Care for Newborn Health and the founding of the Global Alliance for the Newborn Care. So thanks, Silke, for joining today and to give a patient view on pre-eclampsia. The stage is yours.
Thank you very much for this kind introduction and also for inviting me together with really high-level experts in this field, Professor Kypros Nikolaidis and Professor Stefan Verloren. It's a great pleasure also giving here the patient's point of view. Just to declare my conflict of interest that our foundation got an honorarium today for the talk. And now I would go today on two main areas I would like to share with you. One is, of course, the patient's point of view on preeclampsia, because I suffered myself 24 years ago, but also why it is important to raise awareness on this day today. And maybe some of you who have seen already in social media accounts today, many activities are going around. And that is one of the reasons why we as patient organizations find it so important to collaborate and work together, but also share our experiences. And this is why I think it is important that we have a voice on this conference, but also on many others in the meanwhile. 24 years ago, I was pregnant. I was 25 years old. I was happy becoming pregnant, and I was pregnant with twins. At this time, I had never ever heard in my life about preeclampsia, but I had several risk factors, like it was my first pregnancy. I was carrying twins. I had already very early protein in my urine, but my gynecologist didn't recognize or didn't know that this is really a high risk for getting a preeclampsia. And in week 24, I got extremely high blood pressure. I always say I looked like a marshmallow figure from Michelin, for example, when they were so heavily, it was not really overweight, it was all water. I had more than 20 kilo water. I felt really sick, and I thought, oh my God, what should happen in this early time? I cannot really already deliver. And this really ugly picture you see here with my ugly trouser, that's the only picture I have during my pregnancy, because I thought, well, I have several weeks in front of us, and so why I should make in the end pictures from my pregnancy. And this is also something which I suffer from today, not really had the feeling of being pregnant. When our children were born in week 25, then finally, so they could save a couple of days, our daughter Lena had only 290 grams, and Lucas had 515 grams. And at this time, I delivered in Munich in a university hospital. I had the luck that one of the key experts at this time on preeclampsia was the chief doctor there. So he really counted hour by hour, and so finally we could save 7 days, and this is why our son Lucas finally survived. We haven't expected this. So I was young, I was healthy, I had no overweight, I did a lot of sport. So I was always thinking, what should happen? So we haven't expected that we just 1 week later lose our daughter. We had never really had thought about preterm birth. I'm a preschool teacher. I worked with disabled children, so I was overwhelmed of being on the other side of the journey and having in the future one baby who passed away and one who potentially has a very high risk of having a very severe disability. And at this time, and this links really directly to the situation we have at the moment on the pandemic, is that parents were separated at this time. So we had only 3 hours a day where we could see our child in this unit. In the NICU, there were only one chair I had to share with all the other moms, so it was not possible every day to kangaroo. And you can see here on the picture, it was also a quite cheap camping chair, so it was even not comfortable sitting there. I had still a lot of water in my body. I felt not really healthy, and I was overwhelmed of my own health. I was overwhelmed of the health of my son, and my husband was, for him, it was not clear the first 3 days if I would survive and if I would have a chance to really survive healthy or having later any kind of complications. And what we had and we all, when we become pregnant and we become new parents, we have, of course, the feeling of we want to have a healthy baby. We want to have a good life later. Our child should have a good life. That's the vision we have. But we wake up and an intensive care unit being overwhelmed with the situation of the technique, don't knowing if this baby will survive, if yes, how the baby survive. The conflict between the couple is quite heavy. And in the first, I would say, 10 years of our partnership, it was not really clear if our partnership will survive, because everything was focusing on Lucas, if he will finally have a healthy, normal life, which was not clear. He had only 515 grams. And you have to imagine it was 24 years ago. after 4.5 months, we went home, we discharged ourselves, and we were so naive at this time frame. We thought, well, everything will be normal. They told us he is healthy, what should happen. We are both preschool teachers, so we live in Munich in a rich area. But at this time, no really follow-up, no information. Even Google didn't exist, what we cannot imagine. So webinars like today would not have been possible at this time. So also the lack of information for us parents was enormous at this time. So even the first years of life, we suffered a lot. In the time on the NICU, we had no support for breastfeeding. Lucas developed a very severe feeding difficulty. And you see here, Lucas, when I fed him when he was tiny. But the next picture with the two young boys, the smaller one, of course, is my son. And the other one is my nephew. He was born 1 week after Lucas, but born normal. And you can see the differences. And my mom always bought the same T-shirts and trousers, and you just can see the differences from the same size of clothes, what it means when you see on the pictures. And maybe many of you have now a smile on your face, or you were laughing. I was crying as I saw this picture the first time, because this made me so clear the difference between my son, who was born 4.5 months earlier, and my nephew Fabrice, who was in the end in the same age, but more than one head taller and a normal boy. And my son, it was not clear what happened later with him. So we really had a very challenging life and still have a challenging life, not only for Lucas, also for myself. And I'm very grateful that Kypros is with us today, because I met him several years ago when we were also talking together on a conference. And he took my hand and asked me how old I am. And I was wondering what in hell this man wants that I'd share my age with him. And he told me, well, lady, you have to make follow-up appointments because you had preeclampsia and you are in high risk to get cardiovascular diseases or stroke. So you should take care. And he organized at this time also that I get appointments in Munich with the right doctors. And so I'm very grateful that also today we are together here, because I'm so grateful that I met him, and I'm now checking my health really once a year and try to live as healthy as possible. But what you see here is also Lucas' development. We had really to fight for a normal kindergarten, for a normal school. He's going. When before the pandemic, he went every day to the gym. We had to fight to bring him in a normal school, because he was born preterm. He was tiny. He has an IQ of more than 120. We really had to fight, even in Munich, that he makes his A-level. And just last week, he got his bachelor in sociology, and he is mentally a very healthy young man. But I would say psychologically, he's very shy. He doesn't like to go to big events. He is really, in many cases, different like other I would say the peer group people. And also I'm happy that I'm still married and not divorced, because this challenge and this really destiny we had was really a big, a big burden on our shoulder, and is still today. Lucas is in the meanwhile also an activist in this issue. He is, as I told you before, 24 years old. He is helping today also on World Pre-eclampsia Day, sending out the message, because he knows in the meanwhile how important it is to get the information at the right time. Also for him, cardiovascular diseases are in high risk. He also had, because of being born so early, an ROP, second stage. So we are happy and grateful that he is so healthy, but we still have to see how his development will be, and also how my health development will be in the future. And therefore, it is so important to raise awareness on this day, but also throughout the year, and that you, in your everyday's work with us as patients, be aware on preeclampsia. I was wondering when I started, if my work as an activist, if we really work on two different worlds, if you maybe work on the Earth and we on the Mars. I don't know. I guess in reality, we have both the same interest. We want the best care of our patients and we of ourselves. And we as patient organization, we want to collaborate with you. So what we have done is in the last years, and we are grateful that the World Pre-eclampsia Foundation has founded this day, and we are really supporting them a lot with our campaign Act Early, Screen Early, because all of these women you see here suffered also from preeclampsia. So we want to share the story, and one of the message we want to send out is that we want to receive early information about preeclampsia when we are pregnant. We also want that gynecologists, obstetricians, midwives know about the issue. And we also want, like Livy says here, and this is where I'm so grateful for Kypros, that we get these follow-up appointments. I had no clue that this is necessary and that I later in life has a consequence out of this disease. And this needs to be transported when the mother or the pregnant or not pregnant, or women who have delivered this. What we have done in the meanwhile as an organization, we developed fact sheets, also in the support of Thermo Fisher, but also in the collaboration with Stefan Verloren or Kypros Nikolaidis. We developed materials that doctors like you have it easier to transport the information to the patients in a patient-friendly language. We have developed a big campaign, Act Early, Screen Early. You saw this also here at the seminar. And we developed statements from experts, also like the two gentlemen today, but also many more. It is from the previous years before the pandemic when we were on the PNS forum. We have in social media different statements, also in different languages. You see here also Leona Poon or Giancarlo Di Renzo, who is giving the messages in Italian or in Chinese. So we really want to raise awareness that people know what is preeclampsia, how can you prevent it, how important is early screening, and what needs to be done after a preeclampsia happened. Many of these people in the meanwhile share their story, and this lady you see here who is showing this poster is a preemie herself, who's 40 years old, and her mother had a preeclampsia. Still today, from the consequences from her mother's preeclampsia, she is mentally, like my son, healthy, but it makes a difference. But what can you do? You can join us today. Please go on our website, or also here in the materials area from this webinar, you'll find this poster. Please download it. Make a message in the social media channels, share it, tell your patients about this day and tell your colleagues about this day, because when we work together, we can really raise awareness and we can make a difference for the future of all the patients who had in the or will have in the future preeclampsia. And I thank you so much for your attention and show you some of these faces who will be for sure grateful when you are now raising awareness on preeclampsia. Thank you so much for your attention.
Thank you, Silke. So thanks for this very impressive presentation. It's clear that it's every time so important that we hear the patient voice, and I'm really glad to see that you're really carrying this patient voice and with the EFCNI doing so much for the awareness of preeclampsia in the patient. So now I would like to introduce the next speaker, and it's really, really my honor today to introduce and to welcome Professor Nikolaides to this webinar. So I don't know if I really have to present Professor Nikolaides because he's such a well-known professor in the fetal medicine world. He worked and have produced extensive research studies on obstetric and gynecology, so more than 1,400 peer review papers, and he has founded, of course, the Fetal Medicine Foundation in 1995. So this charity organization is really promoting the research and the training in fetal medicine around the world. And the foundation has donated more than 45 million pounds to this purpose. So thanks, Professor Nikolaides, for joining us today. And I will leave you the stage to talk about the prediction and prevention of preeclampsia.
Thank you, Pascaline and Thermo Fisher for the invitation. I'm grateful to be sharing today's panel with Silke and Stefan. Silke has told us of the importance from her own personal experience of preeclampsia, not only during the course of the pregnancy, but also for years beyond, not only for the mother, but also for the child. I believe that in the last 5 years, there are two important developments in this field. The one that I will be presenting on early prediction and prevention of preeclampsia, and the one of the work from Stefan on the diagnosis of the condition and the differential diagnosis from when a woman presents with some of the signs of the condition. It is unfortunate that despite the extensive evidence in this area for both of those topics, in a great extent, there has not been the adequate clinical implementation that we should have had in at least most of the developed countries of the world. And therefore, it is important to continue to campaign in this field. But let me discuss the concept of screening during the course of pregnancy to identify women that are at high risk of developing preeclampsia. There are such systems in place at the moment in most developed countries, and they rely on asking women when they first get pregnant a series of questions. This method of identifying a high-risk group is simple in many respects to perform, and it is obviously inexpensive. It relies on a few questions. But the question is, how good is it as a system of identifying the high-risk group so that it can develop strategies to prevent them from developing the condition? Well, unfortunately, it is quite poor as a predictor, as a screening test. It at best identifies only 40% of the women that will develop preeclampsia, and at a screen positive rate of 10%. It classifies 10% of the population as being at high risk, and the so classified high risk group contains only 40% of the women that will develop preeclampsia. And in this era where a lot of emphasis is placed on personalized medicine, of course, this test fails to give an individual risk to each person. They are merely classified as being at very high risk or no risk at all. It has taken us 40 years to produce this one slide. Sometimes science is a bit slow. This slide summarizes the work of these 40 years, where a new method has been developed for identifying the high-risk group. And this method combines information from the medical history and previous obstetric history together with 3 measurements at the 12th week of pregnancy. And the 3 measurements are the measurement of the blood flow from the mother to the placenta, the uterus, the baby, through the uterine arteries with Doppler. The second is the measurement of blood pressure, and the third is the measurement of PABA, or preferably PLGF. And with this approach, at the 12th week of pregnancy, we can identify a high-risk group that will contain 90% of the women that will develop very early the most severe types of preeclampsia, with the consequences that we have already heard from Silke. About 75% of the cases of preeclampsia before 37 weeks, and only about 40 to 45% of preeclampsia at term. And in a study in England, where we had to compare head-on the traditional method with the new method in 7 hospitals of the National Health System, involving more than 16,000 women, we found indeed the blue, the Fetal Medicine Foundation method, the red, the traditional method based on history, the performance. And you can see that irrespective of whether we are looking for early, preterm, or term preeclampsia, the performance of screening by the Foundation's method was twice as good as that achieved by what we have at the moment. What I now want to address is some interesting discussion points. In many advanced countries and developing countries of the world, we have had for the last few years first trimester screening for Down syndrome and chromosomal abnormalities. And this method involved the measurement of nuchal translucency, PAB-A, and free beta HCG. So is it sufficient to measure PAB-A, or do we need to spend more money to also measure PLGF? And this slide summarizes the evidence. And the evidence is very clear. Based on 60,000 patients examined in the first trimester, we found that, yes, PAB-A can add a little bit over what we get from the history alone, but PLGF is much more effective in the prediction of preeclampsia, especially when we are combining history, blood pressure, MAP, and uterine artery PI with a biochemical marker in the name of PLGF. However, if we don't have enough money to measure PLGF, the ROC curves on the left show that we could achieve a similar performance of screening by merely increasing the screen positive rate to achieve the same detection rate. And we do so by increasing the screen positive rate by about 3 to 4%. So in order to achieve a 90% detection rate of early preeclampsia, instead of classifying 10% of the population as being at high risk, we classify 14% of the population, and therefore we give aspirin to a higher proportion of the population. Another important element for people to be aware of that are offering this test and they are planning strategies of screening is that obviously the performance of screening for anything that we do, whether it is cancer of the prostate or screening for Downs, it very much depends on the prior risk, the prevalence of the disease within a given population. So in Black women, the risk of preeclampsia is 3 times higher than in white women. And therefore, if we are screening a heterogeneous population like the one we have in London, you need to use the same risk cutoff to classify women as being at high risk or not. But if you are screening a predominantly white population, then you may have to select a different risk cutoff to maximize, in some respects, the benefit of screening. So I propose that in some European countries where the population is predominantly white, to use a risk cutoff of 1 in 150 and achieve a detection rate of about 80% of preterm preeclampsia at the expense of classifying about 15% of the population as being screen positive. Another element that is always interesting in screening is this concept of contingent screening. When you are screening a population, do you need to measure everything on everybody? I mentioned that the performance of screening by a combination of history, mean arterial pressure, uterine artery Doppler, and placental growth factor is about 90% detection of preeclampsia before 32 weeks and 75% detection of preeclampsia before 37 weeks. Can we achieve the same performance by avoiding to measure all 3 biomarkers in the whole population? The answer is yes, we can. And if, for example, the primary method of screening for everybody is the maternal history, then we only need to measure the 3 biomarkers in 70% of the population, because some women are at such very low risk that, based on their history, that irrespective of the results of the biomarkers, they will always remain low risk, and other women are such a high risk on the basis of their history that, irrespective of the biomarkers, they remain at high risk. If we do not have facilities for the measurement of uterine artery Doppler, and we can screen the whole population by mean arterial pressure and PLGF, then we can reserve the measurement of uterine artery Doppler to 30% of the population. If, on the other hand, we want to save money from the measurement of PLGF, we can do screening by mean arterial pressure and uterine artery Doppler and reserve the measurement of PLGF to about 40% of the population. Let me address another important question now. In the calculation of the risk, it very much depends what happened to you before, if you have had a previous pregnancy. So if I take a woman with certain maternal characteristics, age, weight, race, method of conception, and so on, that if she was in her first pregnancy, her risk would be about 1 in 100. This woman, if in the first pregnancy had a baby, it had a complication of preeclampsia and she delivered at, let's say, 30 weeks, her risk in the next pregnancy will be 1 in 10. If the same woman with the same characteristics had a previous pregnancy and she delivered at term and she did not have preeclampsia, her starting risk in this pregnancy will be 1 in 700. This is simple, but life is not always so simple. What do we do for a woman that had a previous pregnancy? In that previous pregnancy, she was at high risk. She was given aspirin, and she did not deliver with preeclampsia, and she delivered at term. What can we do with this woman in this pregnancy? Shall we classify her as being a non-preeclamptic, or should we classify her as one that was potentially preeclamptic? The answer is very difficult to work out. There are major differences in the implications of how we would classify that woman, and a simple way, a compromise way, is to classify her as being nulliparous. Now, another extremely important element of screening is that there must be an infrastructure when you're screening, so that there is continuing training, education, and audit of the results. And in some countries, certainly in England, we have a national program of screening for Down syndrome, for example, where all of the results from the measurement of nuchal translucency and biochemistry are sent to one centralized place of a mathematician who examines the distribution of the measurements and then tells the laboratories that they need to change their method of analyzing their results, and they need to change the way that the obstetricians or the sonographers perform the measurement of nuchal translucency. If the measurements fall in the green zone, then they are doing well. If in the yellow zone, they are not doing very well, but not too badly, they are getting a warning that they have to modify their methods. And if they're in the red zone, they are stopped from providing a service until they retrain and they find out what is wrong. Otherwise, they're giving wrong results to the patients. So an extremely important element of screening is the development of an infrastructure that ensures that the method of screening is appropriate. Now, in terms of the prevention of preeclampsia, we carried out a study involving 27,000 women that had this method of screening. We identified the high-risk group, 10%, and then we randomized them into aspirin, 150, not 75, 150 milligrams from 12 weeks to 36 weeks. And we found that we can reduce the rate of very severe early preeclampsia by nearly 90%. So if Silke had this method of screening, we would have reduced her chances of developing severe early preeclampsia by 90%. If you look at 34 weeks, reduction of 80%. If we look at 37 weeks, reduction of 60%. But there was no impact on the risk of term preeclampsia. Another extremely important element of screening and treatment with aspirin was the major reduction in the length of stay in the neonatal unit. In most healthcare systems, the most expensive element of care is not of obstetrics or delivery, but actually the time spent in the neonatal unit by the child. And the vast majority of time spent in the neonatal unit belongs to babies born before 32 weeks, and since first trimester screening identifies 90% of these babies born before 32 weeks, and first trimester administration of aspirin in the high-risk group reduces by 90% the chances, then we have a dramatic reduction in the length of stay in the neonatal unit. And this alone can have major health economic implications. This reduction in cost is much, much more than enough to cover the cost of screening. Let me now address a different issue, where we have been and where we are in some respects going. What are the useful biomarkers for preeclampsia? In the first trimester, mean arterial pressure, uterine artery Doppler, placental growth factor, and PABA if you don't measure PLGF. In the second and third trimesters, PABA is not useful, but a new biomarker becomes important, and you will hear more about that from Stefan, FLIT. But FLIT goes up only a few weeks before the development of preeclampsia, and therefore it is not a useful biomarker in the first trimester. Similarly, if we look towards the end of the pregnancy, then the uterine artery Doppler is not a useful biomarker. In the recent past, there has been a lot of interest on maternal cardiac function because of this association between preeclampsia and long-term maternal cardiovascular morbidity, and the suggestion that this may actually be the basis for the development of preeclampsia. Maternal cardiac dysfunction, the cause of preeclampsia. We have carried out very extensive studies, screening studies, and this is an example of a study in more than 2,000 women that were routinely screened at 20 weeks with maternal echocardiography. And we indeed found that systolic dysfunction is increased and diastolic function is decreased in women that will subsequently develop preeclampsia, the red, compared to those that do not develop preeclampsia, the blue. However, when we looked at the maternal characteristics of the women that developed preeclampsia and we adjusted the results of the echocardiography for these maternal characteristics, there was no additive effect from the maternal cardiac function in the prediction of preeclampsia. The women had dysfunction in their heart because they were overweight, or because they were advanced maternal age, or because they were of Black racial origin, or they had chronic hypertension or diabetes. Therefore, the explanation for the maternal cardiac dysfunction was the maternal characteristics rather than as a predictive event for preeclampsia. In contrast to that, looking at the eye of the women was a useful predictor of preeclampsia, because if we use ultrasound to look at the eye, this is the orbit, the black area that you see on the top. If we put color Doppler, we see the color behind the eye, and this is the ophthalmic artery. And then we get this characteristic waveform with two waves in systole. The first wave is from cardiac contraction, and the second wave is reflection from the peripheral resistance. And in women that will develop preeclampsia, there is increased peripheral resistance for several weeks before the development of preeclampsia. And this is a new biomarker that is being assessed, and I will find out to what an extent it will be useful over and above those that we already have. Now, I have already mentioned that you can screen and to a great extent prevent preeclampsia in the first trimester. But you know, that is not the whole story, because of course, even if we look at preterm preeclampsia, we only identify at 12 weeks about 75% of those that will develop this preterm preeclampsia. We give them aspirin, and we only reduce the risk by 60%. Major victory over what we had before, but still not good enough, because there will be many women with preterm preeclampsia that would not be identified in the first trimester, and even if we did identify them, we will not prevent their preeclampsia from happening. Therefore, there is a need for continuing screening during the second and the third trimesters, and we are working towards a model so that all women at 20 weeks have screening by a combination, again, of maternal factors, blood pressure measurement, uterine artery Doppler, and to me, preferably, the measurement now of PIGF and FLIT, and I'm very grateful to Thermo Fisher for supporting this research, because the logic of that is to stratify women into different risk categories so that we define the intensity of subsequent monitoring of the pregnancy. In an extremely small section of the population that are at very, very high risk, we can just give them the blood pressure and teach them how a machine and teach them how to measure their blood pressure at home every week, every week, starting from 24 weeks. And then another group, a high-risk group, about 1 to 2% of the population, that can start being followed up from 28 weeks, and then a group of about 10 to 15% of the population that is being reassessed at 32 weeks. And then everybody, again, has to be reviewed at 36 weeks, because it is only at that time that you can begin to identify the majority of women that will develop preeclampsia. And this is illustrated in this slide, where screening at 12 or 20 or even 32 weeks is just not good enough for the prediction of term preeclampsia. To do so, we need to screen at 36 weeks. And then at the back of this idea, we carried out a major randomized trial involving nearly 30,000 women, identified the high-risk group, and then randomized them into pravastatin versus placebo. And unfortunately, we found that that was not useful for the prevention of term preeclampsia. Perhaps we will be seeing models in the future where we screen at 36 weeks, identify the high-risk group, and on the basis of that, define the timing of delivery. An extremely high-risk group, small, 3% of the population, where you can be recommending delivery at 37 weeks, another group of about 10%, where delivery can be undertaken at around 38 weeks, and then the rest, nearly 90%, that can carry on until they go into labor at up to 40, 41 weeks. I thank you for your attention.
Thanks a lot. Thanks, Professor Nicolaides. Very interesting presentation. So thanks for sharing all this new advancement in the research for preeclampsia. So now it's my pleasure to welcome our next speaker. So it's Professor Verloren. So Professor Verloren is a professor of obstetric at the Department of Obstetric in the Charité University Medicine in Berlin, in Germany. Professor Verloren has done an extensive research on preeclampsia and is, by the way, the head of the Pre-eclampsia research group at the Charité. Professor Verloren has published significantly and very extensively on especially the use of the biomarker PLGF and SFLT and the ratio to improve the clinical management of pregnant women in second and third trimester. And Professor Verloren will present today about the prediction of preeclampsia associated adverse outcome. So thanks, Professor Verloren. Stage is yours.
Good afternoon, ladies and gentlemen. Thank you very much, Pascaline, for the nice introduction. It's a huge pleasure for me to share the stage with Silke Mader and Professor Nicolaides. And I'm very grateful to Thermo Fisher to organize this webinar today at World Pre-eclampsia Day. So this is the World Pre-eclampsia Day, and as Silke has already very nicely said, we can see how it increasingly becomes recognized. So a lot of organizations have adopted Pre-eclampsia Day. There's a lot of noise around, and I think this is a great success. So I think it's worthwhile, after the very elegant talk of Professor Nicolaides, as always, to sit back and think about what is actually preeclampsia and what comes to our mind when we say the word preeclampsia. And I think for most of us, it's very clear, despite the changes of the definition that I will be going to address later at the end of my talk, despite all these changes that have come in the recent years, when we think about preeclampsia, we think about hypertension and proteinuria. And that is the diagnostic gold standard. But at the same time, we as practicing obstetricians know that the simplicity of that definition is in sharp contrast to the complexity of the disease. Because with just these two diagnostic tools, we cannot say much about our patients that present at high risk for the disease, and that these two tools are actually very poor at predicting the complications of preeclampsia. And that this is the case has been shown many years ago. 20 years ago, to be precise, the group of James Roberts from the United States has looked at the ability of definitions of preeclampsia to detect adverse outcomes of preeclampsia. And what he has found is that the positive predictive value of the definition of preeclampsia to detect preeclampsia-associated complications is just 20%. So in other words, just 1 out of 5 women who receive the label preeclampsia experiences an adverse outcome connected to it. And in this paper, he has concluded that neither blood pressure nor blood pressure and proteinurias are accurate predictors for outcome. They may be convenient to measure, though we know that measuring the blood pressure correctly is very difficult. However, they may be convenient to measure, but they're not specific enough to define this disorder. And one of the results is overdiagnosis and potentially overtreatment. And 20 years ago, he postulated that the ultimate solution of some of these problems might rely in the identification of a good biomarker, which should be sensitive and specific for the pathophysiology of the condition and can be used then in conjunction with the clinical tools or even alone. So this was 2001. And just 2 years later, the group of Anand Karamanchi from Harvard Medical School came up with his seminal paper where he first described the importance of the angiogenic and anti-angiogenic factors for diagnosing preeclampsia. So this very small clinical study following an analysis of placentas with Affirmatics CHIPS technology, 2 things popped out. This was SFLT and PLGF, so he took them into a small clinical study, and he was able to show that women who had preeclampsia had significantly elevated placental expression and circulating serum concentration of this anti-angiogenic biomarker SFLT. And he could show like a dose-response relationship. The more severe the disease, the higher the dysregulation of SFLT. And at the same time, he was able to show that in these women, the more severe the disease, the lower was the level of circulating PLGF. This was the clinical part, but most importantly, in the experimental part, there was an animal model also described in the study. he has shown the relevance of this system for the pathophysiology. So he transfected pregnant rats with S-FLIT. So via adenoviral delivery, he made them overexpress S-FLIT. And what happened to these rats who had too much S-FLIT? They developed hypertension, proteinuria, and glomerular endotheliosis. As you can see in the stainings, the lower line shows the rats who overexpressed S-FLIT. So in giving them S-FLIT, they were made preeclamptic. They were expressing features of the disease. So how do we perceive the pathophysiology of preeclampsia? As we've heard earlier, also things like the maternal heart are actually attributed to be causative for preeclampsia. But in the end, we do not know what is the root cause. We know that the immune system plays an important role. We know that genetic factors play an important role. But what we know for sure that in the center of the pathophysiology is the placenta. And if we look at this graph, just in the lower left corner are the diagnostic criteria, hypertension and proteinuria. However, the preeclampsia-related outcomes are what is of interest for us. And the preeclampsia-related outcomes are not just hypertension and proteinuria. It's all that results of a dysfunctional placenta, such as IUGR, HELP syndrome, eclampsia, also placental eruption, and indicated preterm delivery. All this is a reflection of the maternal syndrome of preeclampsia, the generalized endothelial dysfunction. And as we've seen, there are the S-FLIT to PLGF ratio that have been firstly implicated in the pathophysiology as the connecting link between the placental disease, which by definition starts in the early first and early second trimester, and connected with a maternal syndrome that happens in the second half of pregnancy. And for the rest of my talk, I would like to show you a bit more about what has been known now about the predictive biomarkers to actually predict the disease. So a couple of years ago, the group of Anand Karamanchi and Sarah Sharana has looked in a prospective study at the ability of S-FLIT to PLGF to detect patients with adverse outcomes. And the strong point about this study was that the clinical endpoint was not pre-eclampsia, as defined by the gold standard, but the clinical endpoint was maternal and/or fetal adverse events. Enrolled in this study were patients who presented at high risk for the disease or with clinical suspicion. So in contrast to the work of Professor Nikolaidis, which is focused on screening, these were women that had already a pre-existing risk. They presented with all this heterogeneous presentation that preeclampsia can have, for example, a new onset of high blood pressure or some unspecific signs such as headaches and so on and so on. And it was looked at the ability of the S-FLIT to PLGF ratio to detect preeclampsia-related adverse outcomes within these patients. So within 2 weeks after presentation, as you can see in this slide, there was a total of 41.5% of adverse outcomes. And here you can see what was regarded as an adverse outcome. It was basically preeclampsia with severe features, so either hypertension plus abnormal liver function parameters or platelets, hypertension and DIC, abruption, pulmonary edema, eclampsia, indicated delivery, or Dopplers. Here you can see some additional subcategories, and it was very clear that the S-FLIT to PLGF ratio was highly significant in identifying these women who developed an adverse outcome within 2 weeks. So it's very important to understand that all women that were included in these studies presented with signs and symptoms, and they were not distinguishable with the normal clinical tools. However, if now focusing on patients below 34 weeks, you can see these women who developed an adverse outcome within 2 weeks, they had a median S-FLIT to PLGF ratio of 285. And these women also presenting at some sort of suspicion of the disease, but did not develop an adverse outcome within 2 weeks. They had a median S-FLET to PLGF ratio of 6. So they were not distinguishable based on routine clinical tools. However, based on the S-FLET to PLGF ratio, it was like black and white. And also, if you look at all patients, there the S-FLET to PLGF ratio was highly discriminative, with 72 for the group of patients who developed an adverse outcome and 16 for the group who did not. And last but not least, it was clearly shown that there was a significant correlation between the level of the S-FLET to PLGF ratio and the remaining pregnancy duration. So here in this Kaplan-Meier curve, the group was split in two, and women who presented at high risk for the disease and had an S-FLET to PLGF ratio of below 85, only a few of them had to be delivered within the subsequent 2 weeks. However, the red curve, women who presented at high risk and had an S-FLET to PLGF ratio of more than 85, only a few of them, more than 80%, were delivered within the subsequent 7 days. So work continued, and I was part of the prognosis study, which is a study sponsored by Roche Diagnostics, a huge study looking at the S-FLET to PLGF ratio to detect women at pre-eclampsia, now at the conventional definition. And there, a cutoff of 38, which was evaluated for the whole gestational range of between 24 and 37 weeks, was looked at. And 1,050 patients were enrolled. And this was, again, the proportion of patients who is reflective of women presenting in hospitals at risk for the disease. Women were included if they have a new onset of hypertension or an aggravation of a chronic hypertensive patient, new onset of proteinuria, aggravation of pre-existing proteinuria, all these preeclampsia-related symptoms such as edema, sudden weight gain, headache, and so on. And it was looked at how good the S-FLET to PLGF ratio is to either rule out or rule in the disease in these patients. And the outcome of the study is that the S-FLET to PLGF ratio at the cutoff of 38 has a very high negative predictive value to rule out the disease. The NPV to rule out preeclampsia in these patients within 1 week was 99.3%. And the flip side of the coin, if the cutoff is exceeded in women presenting at high risk for the disease, then the positive predictive value that these women will develop preeclampsia within the subsequent 4 weeks is 36.7%. So instead, 1 out of 5 patients, 1 out of 3 patients were identified. And then in a post-hoc analysis, we looked at the ability of the S-FLET to PLGF ratio to detect a composite endpoint of either preeclampsia and or preeclampsia associated adverse outcomes. And if you look here, if the cutoff of 38 is exceeded, then the positive predictive value is 66% that within the next 4 weeks, preeclampsia and or adverse outcomes will appear. That means 2 out of 3 patients who have this cutoff of 38 exceeded will actually develop the disease or adverse outcomes connected to it. So this was all data generated from well-planned clinical studies. I must say, at our institution at the Charité, we use the S-FLET to PLGF ratio as part of our routine clinical workup for preeclamptic patients since many years, since 2010 to be precise. And we have recently looked at these patients and looked in a real-life cohort how good is the S-FLET to PLGF ratio to predict preeclampsia-associated adverse outcomes, or in other words, the recommendation that were based on these prospectively evaluated derived cutoffs are in a real-life setting. So we included 1,117 patients from the years 2010 and 2018, and we looked at basically suspected preeclampsia. We looked at patients with abnormal uterine perfusion. We looked at patients with history of preeclampsia, and also we included patients who are screen positive in first trimester screening according to the FMF algorithm, which is part of our routine clinical practice as well. We screen our first trimester patient based on the algorithm that was developed by Professor Nicolaides. So what were the outcomes? Adverse outcomes were recorded in 322 of these 1,117 women, 28.8%. And of those, 5.2% were maternal and 26.5% were fetal adverse outcomes. So much more frequent, obviously, things like preterm delivery and complications associated to it. So in the final diagnosis, 31.4% had preeclampsia and 19% had ILGR. So this was, again, truly a high-risk cohort and not a screening cohort. So as expected, we were able to show that the S-FLIT to PLGF ratio was highly discriminative between these women who developed adverse outcomes and these women who did not. And also the delta between two measurements had a clear tendency, though was not significant. So a daily change of the S-FLIT to PLGF ratio of 0.3 in the ones without adverse outcomes versus 2.7 in the ones with adverse outcomes. And finally, we looked at the remaining pregnancy duration in the group of patients that presented the different risk categories. So 38 to 85 and more than 85, it was clearly shown that we had the higher the ratio, the shorter the remaining pregnancy duration. And this was the case before and obviously also after 34 weeks of gestation. And then we looked at maybe the S-FLIT to PLGF ratio at the given cutoffs, or a standalone parameter can be improved by integrating it into a regression model. And so we did, and we were able to show that indeed, and as expected, integrating all other available clinical information, such as the gestational age, such as hypertension, blood pressure measurements, and proteinuria, increased the area under the curve and was also able to substantially increase the positive predictive value in these women. So I think what we have shown very clearly is, and confirmed in a real-life setting, is that the S-FLIT to PLGF ratio improves detection of preeclampsia-related adverse outcomes. And we have shown that using other clinical information in addition to the cutoff increases the performance. So I think it's clear, and this has been shown now convincingly over the time, that the S-FLIT to PLGF ratio is a sensitive and specific test to detect not only preeclampsia, but preeclampsia-related adverse outcomes, and that it improves the diagnostic and predictive accuracy of our current tools. Integrating it into diagnostic algorithms will have the potential to reduce maternal and/or fetal morbidity and mortality. And I want to spend the last couple of minutes to show the impact of the new definitions of preeclampsia on our clinical work. So ACOG were the first who came up with a new definition, who relativized the role of proteinuria. In the absence of proteinuria, they said, also thrombocytopenia, renal insufficiency, and other organ functions can be then said as preeclampsia. The ISSHP was the next society in 2019, actually, that's a spelling mistake, that also included fetal growth restriction. The group of Kypros Nicolaides, I would like to show two of his works here, because I think they're very important for understanding what actually is preeclampsia. Now looked at what these new definitions actually do. First of all, to how many patients are labeled as preeclampsia, and what's the share of adverse outcomes here. And he was, first of all, in his paper from last year, able to show that with the new definitions, more women actually are labeled as preeclampsia. And when we think back what Jim Roberts has said, this is maybe not the right way to go. And in this paper, he looked at two readouts, the gestational age at delivery and the birth weight at delivery. And in contrast to the old definition of preeclampsia, the more strict, if you will, using the ACOG and the ISSHP definition shifted the curves to the right. So babies were born at later gestational ages and had a higher birth rate center. So the disease was milder, actually. Recently, another paper from his group in collaboration with the group of Laura McGee looked again in a prospective study including 15,000 women presenting in the third trimester of pregnancy at the ability of the new definitions to detect adverse outcomes, the adverse outcomes that I was talking about. And they described and compared the traditional versus the ACOG, the ISSHP definition, also including the fetal growth restriction, and a fifth definition, which also included the angiogenetic factors. The outcomes were severe maternal morbidity. And first of all, the more factors were included in this definition, the higher was the proportion of pregnant women that were included. However, and this is, I think, very important, the best definition to predict and detect preeclampsia-related adverse outcome was the ISSHP definition, including Doppler parameters of IUGR and the angiogenic factors. In the ISSHP MFAI definition, the significant proportion and significantly more and at a better detection rate adverse outcomes was detected when Doppler parameters and angiogenic factors were included. And to finish, we in Germany, we also have a new guideline and we revised our understanding of preeclampsia. So in our case, preeclampsia is diagnosed when there is any hypertension plus an organ dysfunction. And what are these organ dysfunctions? They are the ones from the ISSHP, but we have already included a dysregulation in so-called preeclampsia-specific marker systems, a change in angiogenic factor levels. So in Germany, preeclampsia can be diagnosed if there is hypertension plus a dysregulation in S-FLT to PLGF. So I think this is the way to go. And if the S-FLT to PLGF ratio will be the troponin of preeclampsia, that I don't know, but I'm pretty sure about it. Thank you very much for your attention.
Thank you, Professor Verloren, for this very exhaustive and interesting presentation on preeclampsia and the use of the ratio to predict the adverse outcome in pregnant women with signs and symptoms of preeclampsia. So now I really would like to thank our three speakers, and I really would like to start now the question and answer session. So please do not hesitate to ask questions. You can do it through the Q&A box at the bottom of your screen. So I can start with a first question for Professor Verloren. So it's a question from Rayan Ayaz. So, can PLGF be used for the treatment of preeclampsia?
Well, yeah, indeed, it would be a logical consequence when we say that S-FLT is the bad guy. S-FLT is causing the trouble. S-FLT is the scavenger that lowers the angiogenic balance by binding the good guys, PLGF and or VGF on a local level. Indeed, there is research in that direction, basically on two aspects, either getting out S-FLT or adding back PLGF. The research in extracting S-FLT from preeclamptic women is further advanced, but actually has stopped for a couple of years. There were apheresis studies looking at the removal of S-FLT. They indeed showed a prolongation of pregnancy. And the research of giving PLGF is in a preclinical stage. There is work from Anand Karamanchi, in collaboration with Anna-Marie Hennessy from Australia, they have a primate lab, and in these primates, they added PLGF, and indeed, they were showing that they can ameliorate the preeclamptic symptoms in these instrumented baboons that were made preeclamptic. However, as I said, this is a preclinical stage. There are no yet clinical studies on giving PLGF, and I think they will not be straightforward because I think it's not that easy given the other biological activities of PLGF.
Thank you, Professor Verloren. I have another question. It's for Professor Nicolaides. So this is about the screening in first trimester for twins. So what would be your recommended strategy for screening twins pregnancy in first trimester?
Thank you. The first point to make, and this is very much related to Silke, is that if you look at the total incidence of preeclampsia in twins, it is 3 times higher than in singletons. But in doing so, over the years, we overestimated one factor. We ignored one factor. But the majority, 60% of twins, delivered before 37 weeks. And therefore, we were producing a bias against the incidence of preeclampsia in twins. If we now look at the incidence of preeclampsia before 37 weeks, the risk for twins is 9 times higher. So carrying a twin pregnancy in itself is a major risk factor for preeclampsia. We then carried out extensive studies looking at the 4 biomarkers in the first trimester: the uterine artery, PI, PLGF, and PABA, and mean arterial pressure, and they are all very similar in direction to what we see in pregnancies in singletons that develop preeclampsia. PABA, not very good, but definitely PLGF, MAP, and uterine are very similar in their pattern to what we see in the singleton pregnancies.
I have another question for you, Professor Nicolaides. So does the aspirin affect on the level of SFLT1 or PLGF?
Yes, good question. I don't know. Well, I do know. In the ASPRE trial, we followed women up at 20 weeks and 32 weeks, and we wanted to see whether the effect of aspirin was to modify the 3 biomarkers, the uterine, the MAP, and the PLGF. And we did not find that it had any major effects. So we don't really know how aspirin worked. In terms of medications that could potentially influence PLGF and FLT, there was a suggestion that pravastatin would do that. And there was a study in England by the group of David Williams. It has taken women with severe early onset preeclampsia, and they gave them pravastatin 40 milligrams to see whether that could modify the values of PLGF, and unfortunately it did not. We also carried out a study that has not yet been published of screening at 35 to 37 weeks, and in the high-risk group that was predominantly driven by the FLT and PLGF, we gave pravastatin 20 milligrams to see whether it could reduce the incidence of preeclampsia. And again, there was no effect either on the incidence of preeclampsia or on the levels of the FLT and PLGF.
Thank you for this answer. So we have another question for Professor Verloren. So what is the false positive rate for a cutoff of 85 for SFLT and PLGF ratio?
Well, so the cutoff of 85 was derived from the early case control studies. And in these case control studies, we looked at the SFLT to PLGF ratio cutoff 85 for below 34 and above 34 weeks of gestation. So if you look at the performance of 85 below 34 weeks of gestation, the false positive rate is 3%. So the specificity is 97% at a sensitivity of 89%. However, after 34 weeks, it drops a bit, and the false positive rate there is, let me think, I think 10% after 34 weeks. And also the sensitivity drops a bit at for 82 to 82%.
Thank you. Thank you. I have another question. So if a patient is having aspirin because of as risk of preeclampsia, but later be confirmed to develop preeclampsia, for example, in week 28, should aspirin be continued to be given considering delivery, or should it be stopped?
Okay, thank you. If I understood the question correctly, a woman was identified in the first trimester as being at high risk. She was treated with aspirin 150 milligrams per day, and at 28 weeks, she developed preeclampsia. I think that it is very true that this woman will soon need to be delivered, and therefore there is no benefit in giving her the aspirin anymore. Somebody presenting preeclampsia. As I had mentioned before, really, people must not expect that just because we treat them with aspirin, the preeclampsia will disappear. Detection rate of 90% of preeclampsia before 32 weeks means that 10% of those women that have the most horrible of preeclampsias, like the one of Silke, will not be prevented. And that is why we must continue. We must not be reassured by the results of the first trimester. We must continue to monitor for this condition.
Mm-hmm. Thank you. I have a more global question to you, Professor Verloren and Professor Nicolaides, is about the counseling of the woman when you have a woman at risk. So how do you counsel the woman? How do you explain to the pregnant woman what will be the prevention, so the aspirin? Because we have one experience with one clinician that explained that a woman was at risk of preeclampsia. The clinician, I would say, inform and ask the pregnant woman to take aspirin starting in first trimester. And by the way, the woman developed a severe preeclampsia, but realizing afterwards that she was taking aspirin only for 1 week. And it's clear that aspirin is only working if you take it every day at bedtime. And so how do you ensure, as clinician, that a pregnant woman that is identified at risk with a preeclampsia screening in first trimester, is she going to, to really follow, get the compliance to the treatment?
I don't know if Stefan wants to mention something. In the paper on aspirin, we demonstrated very clearly that the performance of the effectiveness was very much dependent on compliance. If you have a chest infection and the doctor gives you antibiotics and you take the antibiotics and you put them in the toilet, it doesn't mean that your infection from your lungs will disappear. So of course, you need to take the drugs. Number one. Number two, we have already mentioned the fact that people must be warned that if they're at very high risk of developing preeclampsia and they're taking aspirin, they are not cured, they may still develop severe preeclampsia. The third question, I think, should be addressed to Silke. In screening for Down syndrome, it was extremely easy. You did not really need to tell anybody what is Down syndrome. People had an opinion somehow of what is Down syndrome. And for some it was good, for some it was bad or very bad. We didn't need to, especially in this era of political correctness, where you have to make your leaflet and your counseling so very vague that you don't really tell them what does Down syndrome mean, just in case you offend anybody. But people had an opinion. Preeclampsia, for nulliparous women, they of course don't know, and for multiparous women, especially that did not have preeclampsia before, they say, what is this condition? I was perfectly all right in my previous pregnancy. How do you stimulate people to go into a method of screening about a condition that they have never heard of before? Well, Silke's job, and she has been doing a fantastic job over the years, is to make people aware of this condition that kills women and babies. But it is very true. It is difficult to counsel people and explain to them about a new condition that they have never heard before, and in screening for it, when the results come back, not to terrorize them that they are going to die or their baby is going to die. So how do you draw the balance? I would like to hear what Silke has to say.
Yeah. Yes, this is really a very interesting question, and it's also important to understand how you as healthcare professionals are talking to us. You have a mix of patients in front of you. You have the ones who are well educated. You have the ones who potentially speak not your language, so it's not the mother's tongue. Then one thing is you as experts have often not enough time to explain. And when you hear that you have such a risk as a pregnant woman, you potentially are, first of all, shocked. So potentially you cannot listen or you cannot understand everything. You have not one patient and that fits for everything what you are doing. So you really need also to invest time to explain what is preeclampsia, what are the consequences of preeclampsia, what is the risk for the baby, what is the risk for you, how often this happens. So you really need time to explain it. This is also why we have, together with the two gentlemen, developed this patient leaflet that you, in an understandable lay language, you get the idea of what is it, how many parents or how many women can get this disease, and what is the consequences later in life, and even what are these kind of risk factors, so that in a lay language you as a patient understand what it is. And you can't imagine or can't expect that they really understand everything at once. So maybe you need another appointment or a week later to explain this again. So when you have such a patient in risk, and you recognize that they potentially are speaking not your language or haven't fully understood, that you make another appointment a week or 2 weeks later and explain this again. And so this is not working like Kypros said, like you have a disease like cancer or Down syndrome, where the majority of people really understand what it is. And this is really important. And that what I also want to say is that it is important that we all regularly talk about preeclampsia when you have pregnant women, and if you have the opportunity to be co-author of a pregnancy book, because this is where we are struggling a lot, that when we want to convince publishers for the pregnancy books to involve the preeclampsia topic regularly, and we really fight now for 20 years in Germany to get in a normal pregnancy book preeclampsia as a topic, because they don't want to write about risky things. They want to have this pink bubble, nice books with pregnancies, no risk, so only fun. And that's not true, as we all know. And so you all are co-authors very often of such kind of books. Please fight with us for such information in normal, regular pregnancy books and journals, because this is the majority of people we are reaching. The people today are going to blogs or to this kind of bubble pregnancy books and not to the risky ones. And so we have here to really to work together to reach the pregnant women. And this is, this is the challenge we face for many, many years. And this is why it's so important not to say it once. It's a little bit like with children. You have to say it several times that they really have it in the brain.
Yes, and maybe two more things on my side with respect to how I counsel women at risk for preeclampsia. So when I counsel them after being screened positive in first trimester screening, I tell them, yes, please take aspirin at the dose of 150, and it will reduce your chances of having preeclampsia by 62%. So basically, I counsel them about the results of the ASPRI study. And I also tell them this is the only evidenced thing that you can do against preeclampsia. And this is also very important because there's a lot of stuff around vitamins, more salt, less salt, and women know this. They pick this up from the internet and say, should I do this? Should I do that? And I say, no. The only thing that is evidence-based, thanks to the work of Professor Nicolaides, is aspirin. And this is the one thing. And the other thing I tell them, and this is what has been already said, taking aspirin does not it does not eradicate preeclampsia. So there is a need for a follow-up. And there is a need that these women need to be seen regularly, that the Dopplers need to be done, and if necessary, if there is some sort of risk coming up, then the SFLT to PLGF ratio helps to better determine if they are at risk. And the strong point about the SFLT to PLGF ratio is that if it is low, then you can very effectively reassure these women. You can tell them, despite you having had preeclampsia in your last pregnancy or now being at risk and taking aspirin, look at this SFLT to PLGF ratio. It is low. You will not have preeclampsia within the next 4 weeks. And this is very effective in reassuring this woman.
Thank you. So I think it's a very good answer. And can you tell me also if the new technology can help for that? So for increasing awareness on the woman side. So because I know that Professor Verloren, that you presented already on an application that would help the woman to better monitor when she's at risk, blood pressure, the symptoms that she's feeling at the moment. So do you think also that it could be an tool to increase awareness on the pregnant woman side, and maybe not only for the high-risk woman?
Yes, I think indeed that the technique of digital tools should be used and should be integrated. And indeed, we are doing work, and it is advancing quite well on an integrated solution where there's a risk calculation on a doctor's platform that is then connected to a patient-side app that this woman can measure her blood pressure at home, can enter her symptoms and get feedback. And also at the same time is reassured, because what we have shown and what we know is that when we use, for example, the biomarkers, we can better stratify whom to hospitalize and whom to send home. But nevertheless, women that have a condition, a sort of experience of preeclampsia or high risk for it, if they're at home, they are also insecure and they do not know what happens now, when will it happen. And if they have such a remote monitoring device that at the one side connects them to their physicians and the other side have monitors her symptoms and give herself feedback, that might also increase the well-being of these women. At the same time, has the potential, I think, to capture adverse events early. But we're still in the early stage, and I hope to come up with results soon.
Thank you. So we are over time. So I have to close this session, and really thanks our three speakers. So thanks Hilke, thank Professor Nicolaides, and thank you Professor Verloren for this really great webinar. I hope that it has been useful for the audience, and we have a lot of questions, but I mean we will not be able to cover them all together today. So I really would like to thank all of you, wish you a wonderful weekend, and by this I will close this webinar. Thanks a lot.
Thank you. Bye-bye.
Thank you.